Thank you so much. It's always a pleasure to be at a dermatology meeting. I invite you guys to join one of our rheumatology meetings and enjoy some lukewarm water so you can come back and be particularly grateful for the gummy bears, Marcona almonds, and sparkling water. So thanks for having me. These are my disclosures. So as I sit in front of patients in my clinic, there's a lot of questions that come to mind. So first is this patient with psoriasis here with joint pain likely to develop psoriatic arthritis, or do they already have psoriatic arthritis? For my patients with psoriatic arthritis, I wonder what therapy should I start for these patients? So I could follow guidelines, but guidelines are made up of a lot of just expert opinion. There's a lot of questions that come to mind every time we're sitting in front of a patient. And the reason that most of us are here today is because we want to use data to solve problems for our patients. This is where real world data really plays a role. Is how do we treat our patients? How do we know what's coming for our patients? Can we predict prognostic factors or risk factors or the likelihood of treatment response? So there's a lot of important questions that need to be answered in psoriatic disease in particular. These include which treatment is best for my patient? Will my patient develop cardiovascular disease? Will my patient develop psoriatic arthritis? And are there long-term differences or in otherwise similar biologic therapies? And this is just a sampling of the many questions that have already been kind of touched upon during this session today. So this is where real-world evidence comes in to help solve these knowledge gaps. A lot of the data that is out there for treatments in particular is from phase 3 and some phase 2 trials. There's a couple phase 4 trials out there, but most of our body of evidence is really within that very confined clinical trials space. What we really want to know is how should a drug be used in the real world? And are the ways that we can better target a drug for an individual patient? These are the kinds of things that we need real world evidence for. These include both observational studies, including registry studies and administrative and EMR data, as has already been discussed, as well as pragmatic trials. So we'll discuss some more of these moving forward. Now, Joel already touched upon the importance of real world evidence in terms of FDA submissions and how the newest FDA director is really highlighting this even further. So I won't go into detail about this. You've already heard a lot about electronic medical record databases, claims data, as well as some registries. And I'm going to touch on some high points there, as well as some things that we need to think about for future innovations. So first of all, when we think about this from the rheumatology perspective, this is particularly important because a lot of the data collected in our clinical trials, or a lot of the patients that are enrolled in our clinical trials, are really not representative of the patients that we see in clinical practice. So for example, you can see here that this is in clinical trials for psoriatic arthritis. Period 1, 2, and 3 refers to the patients, the time periods in which these patients were enrolled. The average swollen joint count is around 14. That's come down just slightly in the clinical trials to 11 and 12. And the average tender joint count in period 1 was 24. It's still around 21 or 23. Can you imagine having 23 tender joints? That's a lot of tender joints out of 68 that are counted. So these patients are really highly active patients. And if you come to my clinic and hang out with us for a day, you don't see patients with 23 swollen or 23 tender joints. Most of our patients have a handful of swollen or tender joints, and that's enough to really disturb their life. But the patients that are in these trials are informing the base of data and how we treat our patients, yet they do not represent the patients that we see. For example, in 2 recent studies, both in a longitudinal observational cohort study that we lead, as well as in the Corvitas PSA registry, you can see that the average number of swollen tender joint counts is very different in our patient populations. The mean swollen joint count is around 2 to 3, and the mean tender joint count is around 5 to 6. So substantially different than those clinical trial populations. Not only is the degree of disease different, the ability to change is different. These patients have a lot more comorbidities. They have many other things going on in their life. They may have depression, and depression may have been one of the reasons they were screened out of a clinical trial. We know that depression impacts the ability to respond to therapy, that we might not see the same things in those patients. So this is another reason that we need to be studying patients in the real world in order to better understand how to select our therapies and how our therapies work, as well as the long-term outcomes from our therapies. So what can we learn from real world evidence, and what types of data sets are available? Now, you've just heard 3 talks on this, so I'm just going to highlight a couple different pieces of this, and then we'll kind of talk more about what's the future. So before we go to the future or even the present, let's step back into the past. So in 2005, J.T. Elder wrote a paper about registries. And this is a quote from his paper back then, that there are three basic types of registry: administrative, clinical, and genetic. Remarkably, little is available in the terms of administrative or clinical registry specific for psoriasis. So we've come a long way. If you just heard the last three talks, back in 2005, there was very little available in terms of these types of registries. And he mentioned that there were some non-disease specific registries such as, or data sets, including finished data sets, for example, but that this was really needed. So in that sense, we have come a long way. We have a lot of data sets available to us now to study long-term outcomes or even short-term outcomes in psoriatic arthritis and psoriasis. So in our, these are just some examples of different data sets that have been used. For example, Medicare and Medicaid. I think Megan Noe has published in Medicare, Medicaid, one of the two. And then Thin, we've worked a lot in Thin within our group. Epic data, I think there's many people who are using electronic medical record data, and you've heard April talk about this a little bit. There's a lot of opportunity there moving forward, and we'll talk a little bit about that. Optum was already mentioned as well as just one example of an administrative claims data set. They also have EMR data. And one of the nice things about that is they can link them. It's a challenge, but that is doable. The Swedish national data set is just another example of a very comprehensive national data system, and then the VA data as well. All of these are very different though. So you can get very different things from each of them, and you can answer different questions with them. And one question cannot be answered in all of them. So you have to really match the question with what's being studied. One example, this was from the Danish data system, in which Joel and I and several others have examined with Alexander Eggeberg the risk for liver disease in patients on methotrexate. So this is an example of a clinical question facing us when we're sitting in front of a patient with psoriasis who's been on methotrexate for some time. Is this patient likely to develop liver disease? And how would I know that? What are the potential risk factors for liver disease in this patient? So this is just one example of an opportunity to study this within a large medical system that has great outcomes available, as well as known validity of the codes for psoriasis and psoriatic arthritis and rheumatoid arthritis, and allows to compare across diseases because it's a more comprehensive system. Now, one of the tricky pieces that's already been mentioned in all three talks is the difficulty in differentiating between therapies. One of the common questions that we ask ourselves as we're sitting in front of a patient is, if I have an option to start therapy A and therapy B, how do I know which is better overall? The randomized controlled trials were performed against placebo, and you can't really combine data from two trials performed against placebo and get a reliable estimate of how one works compared to the other, because the populations enrolled may be different. So we struggle with the same thing within real world data. Patients are enrolled and followed over time, and they may start a therapy for one reason or another. And the physician and the patient are really the only ones that can tell us why they started that therapy or not. But we're looking in aggregate across many different patients who have started therapies. And what we have to keep in mind is that people, the group starting therapy A and the group starting therapy B may actually look very different, but it's hard to see that. Propensity scores have been mentioned several times as one method for dealing with this. I think one of the cautions is that propensity scores are only a partial correction of confounding by indication. So we have to make sure we don't rely on that solely. So when you're reviewing a paper that has a propensity score matching or adjustment, make sure you don't kind of yield to that method. You still have to be able to collect the data to understand the differences. And I'll say that many times we don't know why those therapies were started or not started. And so you have to always take that with a grain of salt still. However, this is something that we should be considering for the future, is how do we collect data in registries and know why or why not someone started therapy? Is there a simple question or a tool that might be developed that might help us understand this when we're thinking about comparative effectiveness studies? Or for embedding comparative effectiveness studies within registries and prospective observational cohort studies, what can we collect that's going to help us understand why someone is starting a therapy or not, so that we can better use those propensity scores and more reliably to collect that unmeasured confounding by measuring it. Many limitations have already been discussed with these different pre-existing data sets in particular, and registries, even though prospective, are often collected data based on a few questions at the beginning. One is in administrative data and EMR data, we're relying on codes. So I'm going to show you in a second why this isn't always helpful, but this is where the importance of validation really comes in. And April highlighted those validation studies as examples. We always need to make sure that someone has validated the codes that we're using for psoriasis or psoriatic arthritis, as well as for the outcomes. So liver disease, for example, or cardiovascular outcomes. Next, we are in these existing data sets are testing associations, not causation. So it's always important to keep that in mind, that there may be other things that explain a particular association. We just published a whole paper on an association that may or may not be causative, but there's a flip of a previous study, and I'm going to show you that in a minute. Observation bias is important, particularly in EMR data sets and administrative data sets. People are followed for reasons. So if you suspect that a patient has a high risk for cardiovascular disease, you're going to be ordering the lipids right there on the spot, potentially sending them to cardiovascular or to preventative cardiology for a full evaluation. And then you may get different information for that patient than someone who wasn't suspected to have cardiovascular disease and then just shows up with their MI. So that always needs to be considered, and there are ways of dealing with that in the data. In prospective studies, this is where we really think about how we're going to make sure we're capturing the same information at every visit. Misdiagnoses and missing data have already been discussed in detail by April, but those are also very important to consider. And this is particularly important as we're using things like machine learning. Machine learning is an awesome opportunity for learning about clustering of data, but it doesn't necessarily account for the missingness. And so it interprets the missingness as kind of part of the data, let's say. So you may be creating biases sometimes. So it's also important to keep that in mind. So this is one example of a recent study that we published in Annals of Rheumatic Disease, in which we examined the association between biologic therapy for psoriasis compared to oral therapy and the risk for development of psoriatic arthritis. So 3 studies have now suggested that treating with biologic therapy among patients with psoriasis reduces the likelihood of developing psoriatic arthritis in the short term. We just published a paper showing the opposite, or suggesting the opposite, that biologic therapy was associated with development of PSA. And this was largely a methodologic exercise to show that depending on how you analyze data and how you consider outcomes, you can flip an association. So you have to be very cautious with interpretation of very detailed data. So in this case, the reason that happened is that people with psoriasis were coming in and seeing their dermatologist or rheumatologist. They said, you probably have PSA, we're going to start you on adalimumab, let's say, or some biologic. They got the biologic therapy, and then they get into rheumatology because it takes 6 months, and then they get the diagnosis of psoriatic arthritis. So it looks like in the short term, they rapidly developed psoriatic arthritis on a therapy. But in reality, they had it at the time the therapy was prescribed. It just wasn't coded yet. So one of the things that we've learned through doing a number of studies like this is to understand the transition from psoriasis to psoriatic arthritis is that everybody codes differently depending on your specialty. So we took all patients who developed psoriatic arthritis, incident psoriatic arthritis, who had at least 6 years of follow-up, and we looked back 6 years to see what kinds of codes were occurring. And what we found is on the top line, you see GPs, and they were coding all kinds of stuff, including, for example, musculoskeletal codes. What you see for the dermatologist is that it's skin or skin or skin. So what we realize is that dermatologists are not reliable coders. So if you are looking at something that dermatologists are trying to code in your EMR data set and looking at that as an outcome or looking for risk factors, you're looking at a very limited data set of risk factors. So important to consider in that each specialty codes differently, but actually dermatologists code very differently from the rest. So advantages of the currently available data is that there's lots of patients in EMR and administrative data sets that are cared for in the real world. So there's lots to learn there about who's using what therapies, for example. In the EMR, as April mentioned, we get an understanding of what physicians intended to prescribe. So in the EMR, you don't see what prescriptions they actually got or that they actually filled. You only see if they prescribed it, and maybe they refilled the prescription, the physician refilled the prescription later. Additionally, in administrative data, or on the flip, maybe, you get what prescriptions were actually filled. So you don't understand necessarily physician intent. These are two very different things. And so depending on the question that you have, you may be more likely to use EMR data if you want to know how physicians are treating patients. But what you want to look at in administrative data is what they actually got. And then finally, international data sets have some fewer gaps because they have some of this data combined and that they actually have the pharmacy records as well as the physician orders, for example. All right, so let's switch to longitudinal cohort studies. You've heard a lot about different registries already and longitudinal cohort studies. I, in rheumatology talks, give this example that if you want to know about what you can accomplish with a longitudinal observational study, just PubMed Daphne Gladman, because she's done so much work with longitudinal observational studies and really contributed substantial amounts to the field about what is PSA? What are the risk factors for bad prognostic outcomes in PSA? What does axial disease look like? How do you quantify that? And also the genetic abnormalities that might be associated with psoriasis, psoriatic arthritis, and long-term outcomes. So many things that we can get from these. Some examples of registry studies, particularly in psoriasis, in psoriatic arthritis, are Corrivitas, the Forward registry, which is a patient-only registry, and I'm going to talk a little bit more about that, as well as the Arthritis Power Registry, again, another patient-facing only registry. And these can be used in lots of different ways, one of which is to better understand phenotypes as well as disease states, because Corrivitas in particular and our longitudinal cohort study called PARC, we have very detailed physician data on the patient's phenotype. I won't go into psoriasis registries in detail because those have been covered already. But this is one of the things we were able to examine in a longitudinal observational cohort study. This is within Corrivitas. We have great detail on physician examination. And so we can see that even if you only look at 6 different features of psoriatic arthritis, you can see how heterogeneous psoriatic arthritis is. And we can really represent this in terms of the bins that are accomplished by psoriatic arthritis, or shown around this circle. So many different phenotypes are represented here. Next steps then can be used to use some of those machine learning machine learning algorithms to kind of start binning people from a machine perspective. So this is from the physician perspective, but how does that differ from what the machines or the computer sees in the data itself? Are there clusters that we're not seeing? Are there bigger groups or smaller groups, hopefully bigger groups, that would be helpful in determining long-term outcomes? So these are opportunities that we have now going forward in some of these registries, is to use these clustering algorithms to identify what are the important subgroups and how do we use those subgroups to identify how we should be starting therapy and what we should be looking out for the patient, whether that be cardiovascular outcomes, for example, or prognostic factors like progression. All right. One other area that's been more kind of in development in psoriatic disease in particular are pragmatic trials. So pragmatic trials are the kind of base of real world data. And Robert Califf was talking about what real world evidence means. Pragmatic trials are particularly important to the FDA. These are randomized controlled trials that are compared to an active control. So you don't have placebo, because we don't use placebo in real life. And you compare these in a real world clinical setting. And then you have as little on the data collection perspective as you can. You make data collection light and easy if possible so that you don't disrupt clinical care. These pragmatic trials are used to inform clinical or policy decisions in the real world clinical practice. Participants should be similar to those getting the intervention in the real world. Endpoints are similar to those endpoints are those that are important to patients and clinicians. In psoriatic arthritis, the ACR20 is the randomized controlled trial outcome for the FDA, but that has no meaning to patients or clinicians. And so that is not a pragmatic trial outcome, something like CDAPSA, which is an easier measure that makes more sense to patients and clinicians, would be a better outcome. The LIGHT study is one example of a pragmatic trial that is comparing, it is randomizing patients to in-home light therapy as opposed to the general light therapy or traditional in-center light therapy. There's also been another pragmatic trial conducted by the I think it was Danish now, I'm actually a Danish group that compared de-escalation of therapy in patients who were doing well using a kind of a treat to target or monitoring their PASI and their DLQI. So that's another example of pragmatic trials. So in psoriatic arthritis, we're getting ready to launch one of our first pragmatic trials where we're comparing 2 active therapies and using the outcomes of importance to patients, using patients who are coming in to switch biologics and doing it at the point of care, trying to put everything on a fake front end so that the patient, signs up, but then they get everything as they would in the real world. But on the back end, we're going to be shipping the therapy to them and being essentially a specialty pharmacy. So we're hoping that this type of trial will form a foundation for pragmatic trials in psoriatic arthritis so that we can understand what are the important outcomes, how do we collect data directly from the patient, but also get important clinician data using a very light touch protocol. So hopefully we'll have more to say about that soon. Other opportunities for innovation, linkage to more data has been discussed several times. Direct-to-patient data collection is important. More directed data collection, including shorter questionnaires, because that allows patients to continue to submit data. Real-time data collection, including using things like wearables and opportunities to maintain people. So one of the things that we're particularly interested in is the transition from psoriasis to psoriatic arthritis, and can we predict psoriatic arthritis in patients with psoriasis? So we've developed 2 new two new studies that will collect patients from data from patients. The first is called the SORCAST study. This uses a mobile application. Jose Scher and Joe Marola are the co-PIs on this, but it's hosted by Pacman and Sage Bionetworks. This is now available for download in the App Store. This creates predictive probabilities from data collected passively. So the iPhone has an accelerometer, and so your walking ability or your walking cadence, for example, has a certain amplitude. If you develop a swollen knee, your amplitude changes. You also have a range of motion of your wrist that can be captured on an iPhone by the camera, and that can change over time if you develop inflammatory arthritis of your wrist, for example. So we've built in a number of different tests that we have now tested, publication to follow soon, I hope, that will demonstrate the validity of some of these tests. And then we've kind of thrown it out into the wild to start getting patients in so we can start examining these different algorithms, and machine learning will be used here as well to define those different algorithms and look at changes in amplitude, for example, or changes in rotation. The camera is also really useful. So if you want to examine dactylitis, for example, you can have a patient take a picture of both of their hands, and then you can measure on the picture the difference between digits on either side of each other. So we're trying to develop a range of physical examination techniques that can be used from home. One of the things about data collection is that patients don't like to collect data, and they don't want to provide much data because they don't have a lot of time. I mean, if you think about us sitting here trying to get through our emails and someone sends us a survey, you're like, okay, maybe I'll do that survey later. I can't do that right now. And then later comes and you forget. So the same thing happens with patients. And so we have to keep that in mind, that we need to be as succinct as possible for them. And that is one of our greatest challenges, is keeping things succinct. But web-based data collection helps us with that, because it can automate things like you can start typing the drug and it can put the rest in. All right, getting the patient voice into data collection is really important. And that is one way is to go direct to the patient. The Forward registry has a variety of different registries for psoriatic arthritis, ankylosing spondylitis, rheumatoid arthritis. We're going to be launching a new psoriasis registry. So this is really exciting, something we hope to do this summer. So this will be a direct-to-patient registry. We'll collect data from them on their body surface area. We will get confirmation of the diagnosis from the physician, and hopefully we'll get a lot of interesting data from them that'll be different from what we might collect from a physician. We'll also hope to link that with SORCAST, so we can have different kinds of data collection from 2 very different modalities, but similar patients, so they can have a linked ID, and then we can use those different data points together. So I mentioned maintaining patients. This is one of our greatest future struggles, is keeping patients engaged. And I think as patients have more and more opportunities to participate in different types of research, we want to keep them on board with these different things. So number 1 is slimming down data collection, but number 2 is giving them a reason to come back. So this is the marketing component of having a registry that we haven't maybe done enough with. So this is, either gamification or providing things that are of value to patients to participate. And that's not generally monetary, that might be other things. All right, a lot has been discussed about connecting data sets. I hope that the Forward Registry and the Psoriasis study will be one example of connecting those. But other examples are connecting registries to EMR data that for the patients participating in this. So in Forward, we're actually going to be collecting an authorization to get EMR data, as well as potentially data from other studies that they may be involved in. So you can imagine then how you can build on a platform like that, like build the genetic study in, for example. So that's what we hope, is that we can have that collaborative opportunity. And I think collaboration is one of the key things moving into the future, and this has been mentioned by all of the speakers. In order for us to answer these most important questions for patients, we really have to be able to collaborate across platforms, across different types we have to be able to collaborate across different platforms and across different types of data. All right, so with that, I will close and open for the panel discussion.